All right, well, thanks everybody for attending today and for inviting me to give a presentation to talk a little bit about digital engagement with patient portals. I have a couple topics to cover, both telemedicine and some of the new legislation around information sharing. And so certainly please, if you have questions, I'm happy to try to answer those questions as time goes along. The material is fairly dense, but hopefully we can move through it relatively quickly. So I'm Doug Van Daele. I'm an ENT doc, and I've been at the university for several years. I'm also the Vice Dean for Clinical Affairs for the Carver College of Medicine. And it's really within this role, as well as when I was the Chief Medical Information Officer, I gained some experience using patient portals, as well as now kind of oversee telemedicine for the organization. So I want to talk a little bit about why telemedicine and telehealth is important to us as clinicians. And I certainly did not really use telemedicine hardly at all prior to COVID, and we'll talk a little bit about that. But I would also say, with regard to telehealth and telemedicine in general, we have in our healthcare marketplace a lot of consumerism. There's a trend toward more consumerism than ever before. And there's really a potential to have new competitors in our markets coming in, whether it's Walmart or Amazon or others. That may be slightly overblown in terms of who might be coming into our markets, but certainly the capabilities do exist more than ever for that to occur. And Huron Consulting does regular healthcare both consumer as well as provider marketing surveys, but certainly in their consumer segments, they've kind of adjusted or determined that there are these 5 different consumer segments. There's the me-focused segment, which these are kind of more perhaps traditionally focused patients. They are less likely to report a medical condition, but they have a really strong perspective around trust, respect, and personal attention. There's also the results-focused group. They may have a slightly higher usage of things like emergency rooms and urgent cares, but they certainly have been a kind of mainstay of the healthcare marketplace for some time. The affordable kind of results-driven, these are primarily will choose a physician's office, for instance, because of the focus really on affordability, affordability as well as trust, and really do rely heavily upon the physician relationship. And then there's the time and money money-oriented. These are perhaps the lowest utilizers of healthcare just in general. They are very concerned about affordability, even perhaps more than the affordable results-driven group. And they have the kind of perhaps least concern with overall results. Now, the digitally inclined, this is a segment that has been growing about 25% year over year from 2016 to 2021. And they have a significant overlap with this time and money group. And so this particular group of healthcare consumers have been growing just generally. But healthcare organizations may be able to bolster loyalty by really appealing to this group, because the thought is that these two groups are the ones that are going to be most likely to be engaged with another outside organization. In the same way, when Huron did their analysis, generally consumers, they want to have pretty much one single point of contact for their care. That doesn't necessarily mean they want to have basically just one physician or one nurse, but they want to have brand loyalty toward kind of one organization. They don't necessarily want to go from one place to another to get their care. About 60% of consumers, however, said they more trust and respect would drive them to switch providers. And interestingly enough, what you see now is that you have a lot more patients who are either interested or have been had a telehealth experience, and most of those consumers really have been satisfied. 72% have been satisfied with that experience. And so what Huron tells us then is that if we agree with their survey methodology, is that patients are being driven quite a bit more toward low cost as well as the digital experience, and seeing that experience is good. And PricewaterhouseCoopers both, again, surveys consumers and providers. And what is interesting here is that there has been a big switch in what consumers are willing to receive in terms of service virtually. And there's a disconnect what provider executives think. So about a third of patients would be willing to receive service virtually for an initial assessment and condition, where provider executives might keep that less than 10%. 37% of consumers may enjoy ongoing treatment of that condition virtually, while only 17% believe virtual visits may be effective for that service. Emergency attention is pretty similar between consumers and provider executives, but mental and behavioral health is somewhat lower actually in consumers rather than provider executives. So again, I think that there is a disconnect right now between what we as providers and sometimes provider executives believe and what consumers are looking for. And then when you ask, for instance, how willing would you be to use do-it-yourself care or have a clinic visit your home for kind of different types? So strep, flu test, etc., remote monitoring, there's a lot of patients who are willing to do that. Also wellness visits and physicals, chronic care visits, and sick or injury care, all are very interested and certainly interested in the virtual world. Another healthcare organization, so Hero Health Consumer Digital Survey, again, has been surveying for many years. But just in the last several years, particularly pre and post-COVID, you see a pretty dramatic increase in adoption of telehealth. And this is adoption by consumers. But I would also say, if you look down here on the lower pane, you'll find they trust a diagnosis most coming from their primary care specialist or a known specialist, as opposed to a technology company or a healthcare focused startup, or definitely physician with artificial intelligence. So I think what this consumerism study would suggest to us is that a lot of healthcare consumers are interested in having virtual care. They are very interested in having it as a single point of care, a single point of contact, but they would really like to receive that kind of care, and they trust diagnoses most from their primary care physician and or a known specialist. So that provides an opportunity for healthcare organizations to really be able to capture that market, to continue to keep those patients within their organization. But it does require us to think a little bit differently about how we're going to care for our patients. And so when there's a lot of different ways of talking about this, is it virtual care? Is it digital health? Is it telemedicine? Well, I'm going to primarily talk about three different components. I'm going to talk about virtual visits mostly, but we'll talk a little bit about digital E&M and e-consults. But these are really the three varieties of digital health or virtual care that we provide at the University of Iowa. So virtual visits, these are a live real-time interaction between patient providers via video visit. There's the digital E&M, so asynchronous interaction between patient provider via a portal messaging. We're talking about MyChart in this circumstance. Or e-consults, which could be a specialty consult between two providers about a patient's care. So I'm going to talk a little bit about our early University of Iowa experience. Some of you may have heard back in 2015, we started UI Ecare. So UI Ecare was a specific website that anyone could go to sign up to receive a virtual visit. This was something that we had a contracted group, Carina is what it was called, to provide on-demand convenient care to a whole variety of patients. Now, these were not our providers. These were providers who were contracted to do this work for us. Even though it kind of looked on the front end like it was us, like the University of Iowa, it was actually a separate electronic platform with its own EHR and other things behind it. It was not integrated into our UI providers. And I don't think the population was really ready for that kind of integration or that kind of virtual care, because we had very, very single-digit patient volumes per day. And that care was quite disjointed. So if the UI eCare individual would say, look, your problem is too much for eCare, you need to go to urgent care, you need to go to the emergency room, there was really no connection. So in 2018, we actually shut down UI eCare, meaning we got out of that contracted group. In 2016, we also implemented e-consults. So these were primary care to specialist consults that really replaced the sidebar question. And we've expanded that over time. I'm happy to come back to this group at some point in time to talk specifically about that. But this is really to eliminate that hallway conversation. Hey, I just have a question about a patient. And it has been able to improve a whole variety of metrics. And so, as I said before, we had pretty low uptake of virtual care. And in fact, prior to COVID, we did perhaps around 100 telemedicine visits a month, which was very low. But as COVID came along, it became very clear that we needed to change the way we work. And I think this is a good example of how important it is when you're implementing any telemedicine project, and we'll kind of talk about this at the very end, that you develop a very clear cohort of patients that you're going to care for via telemedicine. So the first thing what we talked about with our COVID screening and testing, we talked about managing patients differently. We wanted to make sure everyone was safe, patients and staff. And we wanted to keep those respiratory illness patients, so those patients who are complaining of symptoms that may be COVID related, out of quick care, urgent care, and the ED as possible. So within 3 days of our kind of initial first positive patient, we set up the telemedicine respiratory screening program. And so what would happen is that patients were directed both on our website as well as if they called our call center. And if they came to a quick care or urgent care, there'd be signs saying, please call us, rather than coming directly in. A visit would be scheduled by the call center with a goal of less than 4-hour turnaround from the call to actual telemedicine visit. And then testing or treatment would be determined by a provider during that telemedicine visit. If indicated, if the patient was really sick, they would be referred to the ED. As time went along in the pandemic, we actually began having certain clinics that would provide IV hydration and even then antibodies by infusion. But after that, we would then, if the patient was indicated for testing, they would have the testing done, most likely in our drive-through, but occasionally we had some walk-in clinics when volumes were particularly high. We had an APP team that would follow up with all patients for positive results, and then enroll those patients in a home treatment team for patients with high risk. They had this packet up here that was delivered to the patient's home, and then also provide education just via MyChart for patients with a negative result. The home treatment team would then follow patients daily, every 3 days or et cetera, depending on the risk or where they were in their care. They would call for a safety check if the patient did not respond, or refer them to the ED. Now, I talked a lot about how all of the bits and parts, but we did gradually transition to a more automated process for screening, MyCharts, self-scheduling, et cetera, as time went along, which is also the important part of having any telehealth program. Is much like our own internal processes, you need continual quality improvement. So you need feedback from your docs, feedback from everyone else, in order to figure out how to make things better. So if I may, I'm going to try to go. Hopefully you can see this website now. And so the website, which is our COVID website, which is readily available to anyone. This didn't initially have all of this content in it. However, now it has content, for instance, that will take you right to the ability to check your symptoms in MyChart, or if you want to log in, but maybe you're just not sure if you're at risk. So you can ask, I'm 18, I have those symptoms, and they're going to say either call or schedule through MyChart. Otherwise, if you're going to want to check again, you're going to say yes, and then I'm going to say no, and then any cough, shortness of breath, runny nose, loss of smell or taste, any of these. And if you have been, then you can then schedule through MyChart. So again, I think that the key here is that this has changed a lot over time. And then we're able to give patients a lot more information. Similarly, if they've already tested positive, and if we did not do that actual positive test, we can then enroll you also in our home treatment team, or schedule a visit into our post COVID-19 long hauler clinics. So that's how we initially started, as I said, with our telemedicine activities. What happened also with our clinics? So with our clinics, we determined that we needed to manage patient differently, but for safety of our patients and our staff, we wanted to communicate with all of our scheduled patients. We kept all the patients scheduled in person who needed an in-person evaluation. We tried to transition those patients to telephone or video if they didn't need it in person. We discouraged patients again and again from postponing or canceling care, and this did lead to a massive change in our care management. We rapidly expanded, so over 2 weeks starting March 18th, really the ability to provide telehealth pretty much across the entire organization. Specific examples of what we changed: transplant evaluation and post-operative visits, psych ED consults, family medicine nursing home visits, and site group counseling sessions. All of them became virtually overnight. When we talked before and listening and understanding with regard to what patients are asking for, we really did focus on a single point of technological contact. We focused on MyChart video. We did already have a video contract in place that was expanded. The problem with video is that it required a download to the patient's iPhone, which was a little bit tricky. The benefit was it does provide group visits as well as screen sharing, but we had more failures in terms of the inability of individuals to either get the download right or whatever. So we did implement Epic Native Video in August of 2020 with a significant improvement. Initially, we did not have screen sharing. We now have screen sharing available, but our group visits still have to be in video. I will say our provider community did push for a non-integrated connection. either Skype, FaceTime, BlueJeans, Zoom, pretty much any one, which would have been fine given that there was a HIPAA secure waiver in place for COVID, meaning you didn't have to have a HIPAA secure program. But we felt it was really challenging to track as well as ensure appropriate billing. It would be also very difficult to give patients information about every single different kind of technology to use in order for them to be successful. So what did that cause in terms of our in-person versus telehealth visits? As you can see, this is what happened in April for us. We had a dramatic decrease in our in-person visits that did come back up in May and June. And here's what happened to our telehealth visits. And a lot of these telehealth visits really are our respiratory illness clinic. And this is what it looked like really in April. This goes down to actually a particular week in April, but about 49 to 53% of all visits, which we had dramatic reductions, were virtual versus in person. Now, in that particular period of time, most of these were being done by telephone, actually, and we were billing for those telephone. But we have almost eliminated the telephone telemedicine visits, and pretty much everything is now by video. So going back to talking about what did it look like during that same period of time in 2020, before and after COVID. And what you see here is that pre-COVID in 2019, we had very little telehealth visits. This is telehealth utilization overall. And what you see in 2020, which we would call inter-COVID, you would see telehealth utilization, and this was the non-influenza-like illness clinic, and then the gray bars show the influenza-like illness clinic. So we had dramatically increased the number of visits that we had started. And what were the patients' perspectives? We had very, very positive patient experience, particularly once we transitioned to the Epic integrated platform. The ILI patients, the respiratory illness patients, couldn't say enough things about our providers. They were very happy. A psychiatry patient in rural Ottumwa got the psychiatric care that they needed. And even our urology telemedicine patients were very grateful for their virtual appointments instead of having to travel for 3 or more hours. And talking to a provider using video, 94% rated the care the provider gave to them as good or very good. And overall ease of scheduling was either good or very good in 93%. Now, you may say, well, that's all well and good. If, for instance, this is a young population that's used to using this technology, well, it is true. The average success rate for all users for connection is 92% first-time success. It's a little bit lower, 85% in ages in 60 to 74. And then in those ages 75 and older, it's still about 3/4 of the time they are able to connect on the very first blush. So that's what happened during COVID. We got a lot of experience using telemedicine. We were doing a good portion of our visits, about half of our visits, even though they were depressed overall, via telemedicine. What has happened since COVID? And so this is digital health usage really in the past 13 months. You can see last year, again, you can see a COVID surge here in November. It has trailed off to some extent, and you can see here in May and June, but this is also a period of time where we historically have had somewhat lower volumes. So the overall experience has really still stayed pretty high. This is a map on the left side of all of our telemedicine visits in the last 3 years by zip code. And here you can see, obviously, this is a lot of our respiratory illness patients here in Johnson County receiving telemedicine care. But we have been able to do telemedicine care really across the state. But one of the downsides in our state is that we do have pretty large swaths of the state that are challenged with a broadband connection. So on the right side here, you see density of broadband connection, and you can see we have some pretty big parts of the state that don't have as strong of a broadband connection as others. So I think we as providers certainly need to continue to push this because it's an important part of how we're going to be able to connect to our patients in the future. One of the things that I'm asked frequently is, you know, what is an appropriate digital health visit for patients? And I think that there's not a handbook that we can provide. This isn't like something I learned in medical school, that these patients are appropriate for telemedicine and this group of patients aren't. But I think that this matrix, which we have created to be able to use internally, has been really important for us when we're trying to determine what are appropriate patients for different kinds of telemedicine. So we have implemented the ability to charge for MyChart. And so these are those digital E&Ms that patients may send in a question. That question may be a new question or may require some medical decision making. We do charge for some of those visits. We talked a little bit about e-consults. So e-consults, this would be a provider to provider question, sending information, for instance, to me as an ENT doc, a patient who has failed typical medical therapy. Are there other, for their allergic rhinitis, are there other things that could be tried? We then go one step further, which would be a MyChart video visit. Less travel would be convenient for the patient. This could be a relatively quick thing. The patient has the equipment, and then I need to see that patient for the services. So example in my practice could be a patient who's on immunotherapy for allergic rhinitis, and I can see those patients in return visit via MyChart. I may also be able, which I've transitioned many of my post-operative visits to MyChart visits. Patients love it and not have to travel. We also, in our outreach hub sites in Des Moines, in Dubuque, in the Quad Cities, and in Waterloo, we can have the patients come in to have their telemedicine visit in that facility where they're seeing me virtually, particularly if the patient either does not have their own equipment or they don't have the broadband connection, as also if they need to see the nurse for something, if there's a multi-provider visit or group visit. We do still have some non-integrated video visits, so either Skype or others, really for those patients who cannot use MyChart for some reason. What about reimbursement? So parity for digital health visit through public health proclamation goes through 12/31/2021. We have Wellmark parity for telephone visits, which has been extended. It was scheduled to end. Payers, including Wellmark, indicated video visit reimbursement will be going beyond the public health proclamation. And major payers are reimbursing consults, so those e-consults that I talked about, so provider to provider, excluding Wellmark. Major payers are reimbursing digital E&Ms, meaning, again, those are MyChart questions that patients are sending in, excluding Wellmark. But we are in active conversation with Wellmark. But again, there is an open question about patient location in order to provide care. As you know, there are some questions about whether those patients have to be within the state of Iowa because my medical license extends within the state of Iowa. Hopefully there will be a extension of the compact soon so that we can extend that further. These are the very specific codes. Many of you may already know these codes, but these are specific codes that Medicare and Medicaid will be paying. You have MyChart message codes, which have kind of low number of RVUs. E-consults, so e-consults, this is when, again, this is a quick question that a PCP or others may have. You get a specialist and a PCP RVU for that. This is one of the workhorses here, so MyChart video visit with an outreach telemedicine visit and non-integrated video visit. Here's all the CPT codes and the equivalent work RVUs. So these are on the fee schedule and are being reimbursed. So let's talk a little bit, go back to a little bit about implementation. And this is a rubric from the American Association of Pediatrics, kind of that gave a overview about the importance and the steps needed. So this is a very kind of linear fashion to talk about how to create an accepted and sustainable telehealth program. And when we talked about the COVID response, I think it's important to think about the COVID response as just one example of how you might be able to integrate telemedicine or telehealth into your organization. And so the first thing everyone needs to do is understand your healthcare system and patient population, of course. And in COVID, we then identified this unique patient care need and then a unique challenge. So we had a disease that we didn't know much about. The challenge is we wanted to cohort those groups outside of our kind of standard workflows. But you may have patient populations similarly that you want to identify how you can manage those patients differently via telehealth. You then identify your resources, which for us, we identified the fact that we were going to use Epic, we were going to use the patient portal, and then we built a model around that, that activity that will address the challenges within the constraints of your resources. However, that next step, which is really critical, and many times we as physicians really want to be able to drive things forward, but we have to identify the others that are going to be critical to our success, sell the model to those change drivers, and then do continuous quality improvement. Another rubric that's used, and this is actually comes from MUSC, who's had a really robust telehealth infrastructure in place since 2013. They have a little bit more comprehensive way of thinking about this, and that is that in the development phase, you need to talk about what is your strategy? What is it that you want to do with telehealth? I would say that we do have a lot of patients that are very interested in being able to be served via telehealth. There's an opportunity because they trust their primary care providers, they trust their specialists, so they want to have a new way of connecting with them. And so in this development phase, you have to figure out, particularly in the clinical arena, what patients are appropriate for telemedicine. And that's really much like we're used to doing for other care kinds of guidelines. What's a patient that's appropriate for getting heparin? What's a patient that's appropriate for a insulin drip or even an insulin pump? So we have to decide what patients are appropriate to be seen or cared for via telemedicine. And then we need to surround ourselves with a whole number of operations and the people and the process and performance and continuous quality improvement. So I think a really important thing, again, to talk very briefly is you need to do a technology assessment. Are your patients ready for it? Are your providers ready for it? Work toward that single point of contract. Try to get these two groups, this consumer group and the executive, those providers, closer together. You know, most providers that I know are not going to want to do a lot of initial assessment, certainly of complex things over telemedicine. But what could you do? So you define those cohorts that are appropriate, and that cohort will likely change with time as you do continuous improvement. And engage the entire team in the process. What's your nurse's role in a telehealth service? What's the medical assistant's role in a telehealth service? What's the front desk's role? Because frequently now, there'll be 10 emails back and forth. This patient's called in, they'd like a telehealth visit. Do you do telehealth for this reason? Do you not do telehealth for this reason? You need to have the whole group kind of on the same page. And then key is continuous improvement. The first 3, 4, 5 times you do it, probably not going to be as successful as you like. So you continue to tweak, you continue to change the nurse's role. Do the nurses call the patient the day before, do med reconciliation? Do they talk about fall risk? Do they talk about these other things beforehand? So again, in terms of a telehealth kind of a program, you really need to be able to do this, define the cohorts, bring the entire team together, and talk about how you're going to care for those patients. So I also want to talk very briefly, because one of the questions that has come about is around information sharing. And so I want to switch a little bit from kind of telehealth to information sharing. And so at the University of Iowa, our patient portal journey, we turned on Epic in 2009. And we started MyChart as a pilot in dermatology in 2010 and rolled it out over 6 months with pediatrics starting in 2011. We released a ton of stuff right away. Notes, so outpatient notes, procedures, labs, radiology, pathology. The final to release time has changed over the years. And on the inpatient side, both H&Ps and discharge summaries. And we had very few, handful of patient safety events reported related to release. An autopsy that result from a child deceased at birth, and a mammogram result concerning for breast cancer. These were kind of 2 examples, but we had just a handful of patient safety concerns. And who was using MyChart? So I certainly had a bias that we would have many patients in the kind of early phase of their life that were using it more than others. But this is really 10 years of data that shows the percentage of MyChart users overall is just a percentage of the patients that we see in a week. So there's not a skewed demographic here, really. It's pretty much all patients use MyChart. And what are they viewing? They're really viewing lab tests and results more than anything else. If you look at the inpatient admissions or the problem list or even the clinic visit details, so that's where they would see clinic notes, patients by and large really were not skewering notes. Some were, but by and large, they were not kind of looking in the very detailed information about the visit. They were looking at their labs and their messages. And it certainly has increased our patient satisfaction with ease of obtaining test results to have this in place over the years. And so that's our journey, but in the information sharing was mandated under the Information Blocking Statute of the 21st Century Cures Act. This gives patient access to more health information than ever before, starting in 2021. The statute really requires the immediate release of daily progress notes, plus all laboratory, radiology, and pathology reports in MyChart, both inpatient and outpatient. So most technical and statutory requirements are easily met with Epic MyChart. There's not a lot of work that needs to be done. We initially put a fair number of delays so that conversations could take place, which we needed to eliminate. And the key to success is guiding patients ahead of time. Changes that you can expect, certainly patients have had the right to their medical records since 1970. Federal rules will make release of information faster and easier for patients going forward. Imaging and test results will have to be available in MyChart immediately, and all notes will be shared with the patient by default when signed final. There is capabilities within MyChart for a clinician to mark that this visit should not be released. I don't know if that's been implemented in your organization, but it's certainly possible. Patients could receive test results before providers and staff had a chance to review. And anticipatory guidance is really important to try to have nurses and docs and everyone else understand what to expect in those results and in those notes. So the US core data for interoperability, so the US CDI, these are the things that are required to be released. So allergies, assessments, care team notes, clinical notes, patient goals, health concerns, immunizations, lab medications, demographics, problems, procedures, provenance, smoking status, implants, and vital signs. And we really implemented updates in March so that we're able to meet most of those criteria. The deadline to meet federal rules to share all of this was actually April 5th. And to meet all federal rules for sharing electronic health information is October 6th. So that is a very quick run through both what I would view as a high quality telemedicine implementation and a telemedicine program, as well as information sharing. And with that, I'm happy to open it up for questions from the group.
What was the rate of acceptance of the release of information to patients of all the info in the chart?
The rate of acceptance?
Yeah.
So in terms of the patients don't necessarily have to indicate whether they've accepted the information. Hopefully I understood that question correctly. Basically, the information will be there for them. They do get a ping from when they can set their notifications when a lab result or something new is in MyChart. But basically, once it's released to them, they can see any of it.
The clarification is acceptance by the doctors.
Yeah, acceptance. So there was a lot of initial concern, certainly back when we made some of these presentations in March and April. You know, I would say if I go back to 2009, I was actually the one kind of going around to each of these groups back in 2009 when we started this journey. The concerns were much higher back in 2009. I would say probably 2/3 of the docs were very concerned, with a third being somewhere between concerned and moderate. But now I would say there was probably only a handful of docs, and the majority of those docs, quite frankly, were our oncologists because of concerns around the way pathology reports are structured and the way those results come back. Again, we haven't had significant patient safety concerns that have been either put in or expressed since we changed everything to immediately release, and that was back in April.
Well, that's all the questions we have for now.
Yeah, and please feel free to send me an email if you have additional questions. I do appreciate everyone's time and your attention.
Thank you for presenting.